Good evening, everyone. Welcome and thank you for joining us at the School of Humanities, Arts, and Social Sciences breakout session tonight. We're so pleased you made the time to be here. My name is Megan Hinckley, and I am a member of the Dean's Office in SHAS. Like you, I am looking forward to learning more about saving by spending, the role of primary care and diabetes from Ari Bronsler, who I now have the pleasure of introducing. Ari is a fourth-year PhD candidate in economics, with research focusing on healthcare access in the developing world. His aim is to demonstrate that efficient reallocation of existing resources and improved organization in developing countries may dramatically improve the quality of healthcare services. Ari's interest in health economics started with his work at Mexico's largest public healthcare provider, where he incorporated big data analysis into diabetes testing decision-making. His undergraduate thesis shows that by using a data-driven decision-making process, it was possible to diagnose twice as many people with diabetes without additional spending. Ari's PhD thesis work at MIT, where he is a Mexico Fund Fellow, focuses on the role that the private healthcare market can play in treating people with diabetes and how easy to access technology, such as mobile phone apps, can break information barriers with patient populations, ultimately leading to better care. So without further ado, I turn the session over to you, Ari.
Perfect. Thank you very much for the introduction, Megan, and thank you very much for coming, everyone. So today I'm going to be talking about a project called Saving by Spending, the role of primary care in diabetes. This is a joint project with Jonathan Gruber, who's my advisor, and Enrique Seira from ITAM. So let me dive right in. Diabetes is a leading health risk worldwide, and the World Health Organization estimates that over 4 million people died of diabetes-related consequences in 2019. And just to give you a sense about how bad that is, the horrible pandemic that we've been experiencing over the last year has killed around 2.5 million people. So diabetes is a really big issue regarding health worldwide. Now, this hasn't always been as bad. In fact, prevalence rates have grown exponentially over the last several years. So for example, prevalence rate went up from 4.7% in 1980 to 8.5% in 2014. And moreover, the increase has been worse for developing countries. So the main reason behind this, most authors argue, is because as poorer countries have access to cheaper and lower quality calories, and they shift away from physical labor, they gain more weight, and as they gain more weight, they have more risk of becoming diabetic, and therefore they become so. So the thing and the good news is that diabetes can be controlled and most complications associated with it can be averted. However, in order to accomplish this, you need to have a large team behind you. You need to have a nutritionist that's going to help you better. You need to have constant monitoring of your health conditions to try and prevent hospitalizations. And you need to be aware that whenever you are out of control, you might require some medication to go back into it. However, with the rates that I have just described to you, the public institutions, particularly in developing countries, cannot handle such an increase in demand. And that will in turn lead to low quality and poor control, which in turn translates into hospitalizations. So to give you a sense of how that looks, in Mexico, which is where we're going to be focusing today, Mexico spends around 2.25% of its GDP on diabetes, but it doesn't have pretty good control in exchange. Actually, some estimates suggest that 87% of this spending is on complications rather than early and preventive care. So what we see in the data is that the hospitalization rate per diabetic in Mexico is twice as large as that of the OECD average. So Mexico is not doing really well. So in this project, we're going to ask, well, the situation is dire, but what can we do about it? And in particular, could the private sector help make this better? So how are we going to do this? We're going to partner up with Clínicas del Azúcar, which literally translate to sugar clinics, and the Lilly Global Health Initiative. And what we're going to do is try and evaluate whether a private clinic or set of clinics can offer a much better solution to diabetes patients. So to give you a sense of what's the difference and what's the advantage of Clínicas del Azúcar versus the regular public checkup, Whenever you go to a public checkup, you have to go there several times. There's usually a long wait. And then let's think about this. You show up, you have to wait for a couple of hours, you get to see your physician, then he demands some laboratory checks, then you go to the lab, you wait for some more. And then while all of this is processing, you have to come back another day to see what your results were and what are the next steps. What the clinics offer is basically you show up and it'll only take you 90 minutes to get a full diabetes checkup. So that's a huge improvement. So when a patient arrives, he goes to the front desk, he gets his eye checked, he goes through nursing, he sees a dietitian, and then with all of that information through an electronic health record, the doctor's office will already have all of this information compiled, and the doctor will make a solid recommendation with all of this information in under 90 minutes. And if that weren't enough, by the time you're leaving, they also have a pharmacy where you can purchase whatever you were prescribed. Currently, they have grown quite a bunch, and they have 17 branches and over 20,000 patients receiving treatment with them. And to give you a sense of how it looks, there are two pictures here. On the left, you can see the front desk talking to a patient that's a new patient that's just registering. And on the right, you can see a picture of people waiting in line to get access to these different sites that I just described. So behind of each of the doors that you're seeing on the right, there's a different station in this streamline of diabetes checkups. So behind one door, for example, is a physician, and behind another one is a nutritionist, so on and so forth. And you go from one to the next, to the next, to the next. So now in terms of how we can evaluate this, the main challenge that we faced is that we needed to make it affordable. So what's the main challenge behind this? So it's not like you can show up to a supermarket and pay for diabetes diagnosis for random people to make sure that they are diabetic and then pay them to show up to a private clinic and enroll if they're not really interested. So that was definitely not a choice. Our second approach was, well, how do the clinics attract patients? And what we realized is that they offer a free diabetes screening to show patients what's the difference and what's their competitive advantage. And after such a diabetes screening, they get sold the product. And if they choose to enroll, then they buy it. So we thought, well, that's amazing. Let's just use that and give them some money to see if they enroll. And we're going to give some money to treatments and not to the controls. We're going to have more treatments enrolling, but controls won't, and then we're golden. But unfortunately, that wasn't the case. We quickly realized that 60% of the patients that go through this free screening end up buying. And that limits a lot how much variation we can have on treatment versus control. And the main reason is, well, let's say that we're going to give $10 to every patient that enrolled, and we have 10 patients. Out of $100 that we're giving in bonuses, 60 of those are going to pay to people that would have bought anyway. So what we ended up doing is rely on the clinic's sales force, which is innovative in the literature. And the main idea behind this is, well, let's rely on the people that know patients best, and let's allow them to try and sell the product first. So the way it works is that you go through the regular process, and then when the sales force arrives, that person is going to try and sell the patient a full price membership. And if the patient agrees and buys, then that's great, and we wish that patient the best, but that person's not going to be part of our experiment. However, if that person doesn't buy, we're going to offer them a super aggressive 60% discount. And that's the point when we're able to get this interesting variation that will allow us to estimate what the causal effect is. And to give you a sense about why we think this is really important, this process is saving us 90% of the budget. So how does our experiment look? We got baseline surveys from nearly 8,000 diabetic patients, and we split them into two groups randomly. You can see that there are around 4,000 people in the treatment group and 4,000 people in the control group. We see that in both groups, 94% of them submit the baseline survey. And we see that the sales force process was really effective in the sense that we were able to screen out 67% of patients that would not have been a good fit for our experiment. So in the remaining 33% of the population, we did our experiment. And as you can see here, both the group from the treatment and from the control are quite similar. And we can see that their HbA1c values that represents the average blood sugar in your bloodstream over the last 3 months is basically the same. Their weight is the same, and their age is the same. However, and crucially, the percentage of the population among the treatment group that use the clinics is 49% in the treatment group, whereas for the control group, it's only 21%. And that's the variation we're looking for. And once we have that, we're going to be able to estimate the effect of CDA. So that all sounded great, and we were doing pretty good. But then, as with basically any other thing in the world, COVID came around. So we were planning to do our follow-up analysis in May, and we wanted to go to people's homes. And of course, we had to delay that process, and we had to adjust our process to make sure that we weren't putting people at unnecessary risk. And unfortunately, we ended up with a lower response rate than we had expected. But on the bright side, we ended up with 1,060 individuals, and we're able to use that sample to estimate the actual effect of the clinics. So here you can see just a picture of one of our team members showing up at a person's house to get a measurement. And another really nice story is that when we did our follow-up, we were able to offer a free diabetes consultation at people's homes. And most of these people were quarantined. So that provided them with something additional that allowed them to talk to their physicians later and sort of try and monitor their diabetes without having to go to a clinic and have a larger risk. So after all of this, what do we find? We find a really big effect on enrolling into the clinics. We find a reduction of 1.2 points of the HbA1c, which is, as I said, the average blood sugar in your bloodstream over the last 3 months. And we see that people are 69% more likely to be in control. So that is a huge effect. What does that mean? According to the medical literature, that should entail around a 35% reduction in complications. So we're avoiding 35% reduction out of the 10 complications, we're avoiding over 3 that would have happened. And moreover, the fact that, as I mentioned before at the start of the talk, that 87% of the spending is in complications, maybe it might even be worthwhile to spend more on early care. So what we find with our estimates is that 55% of the spending in this additional private solution for patients would have been recovered in direct hospitalization costs, as the chart shows. And that's, let me be clear, that's only highlighting the direct costs that would be recouped from avoiding hospitalizations. If we consider that diabetes is the leading cause for disability in Mexico, and that many people have to skip work because they're feeling really sick, then this would definitely be worth it. So then another interesting question is, well, what's going on? What is changing in these patients that's leading them to have such a big effect? So what we see is that they definitely receive way more healthcare. They get 35% more visits. They change from more invasive to less invasive medicine, and they also comply way more with physicians' prescriptions. So what we see is that before, nearly 30% of patients would skip their meds when they were feeling good, and afterwards, basically nobody does it. Moreover, we also see some change in behavior. So basically they're dieting more, they're exercising more, and that is all great. But then there's another question. So are people receiving better care at CDA, or is it just the fact that CDA and these private clinics being more accessible and nicer and making people feel better and so on, leading them to get more care? So is it because they're innovating in the way they provide care, or is it just because they're innovating in the way that they attract people and make them get more care? And how can we answer this? We're going to go back to the largest insurer in Mexico that treats over 70 million people and exploit all of their administrative data to try and get a sense of what the return to an additional visit with them would be. And what we find is that the return to an additional care at IMSS is comparable to what we see in the public, to what we see in our experimental estimates. So it seems like improvement is coming from the access to care. So the fact that you have more access to care leads you to have more care, and the fact that you have more care leads you to be better. So this leads to a main policy recommendation, which is let's make care more attractive so that people actually show up. And through that care, we're going to save a bunch in hospitalizations and make people way better off. So what could the government do? One idea might be to hire private entities like the one we work with, and then make sure that people can just go to a more accessible and nicer scenario. Another idea might be to invest in making their own service more attractive so that people show up more. And another one might be to include all of these new technologies to make sure that the waiting times are shorter and people enjoy going more. And so that's our main conclusion from this experiment. But we realized that there's still a lot to do. Even with these huge benefits that I described, around 50% of the people leave before a year is done. And one immediate question that we're seeing is, well, are these people making a mistake? And if they are, what would be the best way to help them stay further? So it's not only about getting them through the door and starting, we want to make sure that they continue their treatment throughout and never become really sick. And by the way, that's what we're going to be working on over the next year with a whole new experiment with the same partners. And thank you very much for coming. I'm really looking forward for your questions. And by the way, if you want to send additional comments or questions, I'm going to leave my email on the screen. Yeah. All right, so I'm going to start with the questions. All right, so the first question is, can I explain why there is an eye check at the clinic and what it entails? So one of the main complications with diabetes that you get is that you have more sugar in your blood than you're supposed to do. So the parts that are farther away from the heart start failing. For example, your feet tend to swell up, and then you don't get enough bloodstream through your eyes, and therefore you start developing these complications called retinopathy. So basically, the idea of having an eye cam right there will allow patients that have beginnings of this complication to be detected immediately and avoid having to go through surgery or, in the worst case, going blind. Yeah, so they have this. So there's a question about how does A1C blood test result come in 90 minutes, or can it be done in less time? And the idea behind these clinics is that you show up and you go through all of these different stations. And while you're going through these different stations, the first station that you're going to go through is the blood test. So they're going to start your blood, and while you go to a nutritionist that doesn't need to know how high your bloodstream is. And while you go get your feet checked, and while you go get checked for retinopathy that we just discussed, while all of this is happening, they're processing your blood, and by the time you get to the actual physician, he already has all the information. And the next question is, how replicable do I think these findings and the care model are in other countries or settings? So this is a really important question, and I want to be clear that we think that this is highly replicable, because what we're learning is that it's not the case that they're doing something that people do not know, or that they just destroyed the market and innovated completely. We think that based on the evidence, what we're seeing is that we just have to make sure that we're being attractive to patients so that they choose to come and they feel comfortable doing so. So what we feel is that based on that lesson, many different care providers could incorporate that into how they design their care, and maybe understand that it's not what the patients should do, and this attitude about, well, this is what you should do, and if you don't do it, it's your problem, but try and understand that from the shoes of the patient, it's really hard to develop 5 or 6 visits every quarter to try and get your diabetes checked. Maybe your job doesn't allow you to do that. And so potentially what one might try to do is, well, let's just invest in making people feel comfortable here. So the next question is, how have we continued this study with COVID, since patients might be high risk? And the answer to this is, we're working closely with the MIT Ethics Committee, and we always go through them, and we're making sure that all of our processes are not adding risk to an individual that at all. So for the second experiment, diving a little bit more into this, we're not messing with any of the process that the clinic is already going through, but we're basically just allowing them to do the process that they do, and we're going to give them online calls and so on to try and provide them more information so that they make better choices. The next question is, was there any kind of telehealth option for data collection? And yeah, there was definitely an option on the table, and we actually ran a full survey trying to get people to measure themselves with blood glucometers that we would send to their homes to try and avoid going there. And at the end of the day, after we tried this, most patients didn't answer or didn't understand how the glucometer would work. And most of them had no idea about what we were talking about. So one of the main things that we're really interested in is we know that 75% of the patients have a glucometer at home and use it at least once a week. But we're just learning that around 50% of them don't know exactly what their blood sugar should be each day. So we're thinking about doing this intervention about helping them understand better where they stand, how much process they had, because interestingly, what we observe in the data is that people react a lot to their weight change on the decision whether to stay or to leave, but not as much to their changing blood sugar, which is what they should be reacting to. And yeah, so the next question is, are there any innovation about diagnosis and how we can do this? And actually, my undergrad thesis was around this. And for example, let me give you an answer on the public institution side of things. So what happens in the public institution is that you have so many individuals that should get tested that you often don't have enough tests to perform on all of them. So the work that I was working on is, why don't we take all of the administrative data and all of these new machine learning algorithms, and we combine that into having some score of risk. And once we have the score of risk of patients, then we can focus on people that really need it and make sure that they get it done. So that's one of the innovations that are going on. And there are several others technology-wise and so on that are happening as we speak. There's another question on, can I explain the random assignment process again? So the idea behind is, oh, and by the way, this is gonna be my last question because we're running out of time. So the idea for random assignment is that we're all aware about the clinical trials that basically either give you a candy or they give you an actual drug, and then they compare how you're gonna behave afterwards and compare if your outcomes change or not. And that way we know whether the medicine worked. So we're trying to replicate that, but we can of course not limit somebody to either get diabetes treatment or not get it, or either comply with the treatment or not. So what we can limit ourselves to as economists is incentivize people to choose to get the service. So what we're going to try and do is wait for people to decline the first offer, so that way we know that most of those guys are people that wouldn't have gotten it, and we're in no way restricting them from getting it anyway. But out of those people that didn't get it but were close, we're going to approach them and say like, hey, would you be willing to take it if it would cost 60% less? And many of them do. And that's the variation that we take. And of course, the control group just doesn't get any discount or set anything. And that's why very few of them use it versus the treatment group, which 49% of them use it. So that was our last question. Yeah. And thank you very much for coming, everyone.
Thank you, Ari, for that fascinating presentation, and thank you to our audience members for submitting so many thoughtful, provocative questions. This made for a very lively and engaging conversation, and we are very grateful for your participation. We appreciate your time and enthusiasm, and we look forward to seeing you at future MIT events. Have a great evening.